Antihyperlipidemia drugs are used in a lot of patients to decrease their risk for heart attack and stroke. The reason is because they've seen that an increase in certain types of cholesterol circulating in the blood can cause an increased risk of plaque development and plaque rupture. The gold standard drug in this section is going to be your HMG-CoA reductase inhibitors, or they're also known as statins. I want you to remember that the powerful statins, the high-intensity statins, are rosuvastatin and atorvastatin. Everything else is a moderate or low-intensity statin. The mechanism of action is pretty complicated, but just think about the fact that we're wanting to decrease the circulating cholesterol. So by increasing the number of LDL receptors on the hepatocytes, they can increase the uptake of the cholesterol, and they can inhibit future synthesis of that cholesterol. Now, these are going to be most effective in decreasing LDL, increasing HDL, and decreasing triglycerides. They're the only drug with this really high triple effect. The side effects are going to be some GI disturbances, but the two we care most about is going to be the myopathy and rhabdomyolysis, meaning that they may have this aching, burning in their muscles, which can signify that they're having muscle breakdown due to the drug. And the second major side effect is hepatotoxicity. So we always start by getting a liver panel on these patients to know where their baseline is. So if we start to see their liver function tests increasing, representing a decrease in function of the liver, we tend to stop these drugs. The interactions are going to be lipid-lowering drugs, not really because we don't want the lipids lowered too far, but more because of the side effects. They're similar in many of the drugs. They have CYP interactions, and different drugs are metabolized either by the liver or the kidneys, and so you'll have to cater that to your specific patients. Now that I've told you that this is the gold standard, I'm going to show you a few other drugs in two major categories. I'll talk about drugs that target cholesterol overall, and then drugs that target triglycerides. Drugs that are going to target cholesterol overall, we're going to start with the bile acid sequestrants. Now, these are really good at lowering LDL, but they don't have any effect on triglycerides, so we don't like to use them in a lot of patients. They're going to have minor side effects such as constipation, but those with triglycerides, especially high-level triglycerides, should not be using these drugs. Exetimbe, or Zetia, as it's called, is going to be another drug that targets mainly that LDL by inhibiting the absorption of dietary cholesterol. Now, these aren't going to be as effective because the amount of dietary cholesterol that influences your systemic cholesterol is pretty small, but they can have an effect on about 20% of the lipid levels. These have some of the same side effects as the statins, and so they're not used together. This is essentially an alternative to a statin. The myopathy and rhabdomyolysis, the liver problems, and so you'll usually stop one and start another, especially if it's ineffective. The next drug that's in this class is going to be the PCSK9 inhibitors. Now, these are monoclonal antibodies, meaning that they're biologic drugs. As a result, they're going to be injectable drugs. I remember being told in school that you probably won't see these very much. They're very expensive, which is very true, but insurance is now starting to cover them quite a bit more, and the cardiologist that I rotated with seemed to really love these drugs. He would use them, number one, as add-on therapy for individuals whose LDL just wouldn't drop regardless of what drug they were on. And number two, you can use it for those people who have failed a statin due to that myopathy and rhabdomyolysis, because we don't really allow them to continue the drug if it's starting to break down their muscles. The only side effect that you really see is some of these autoimmune effects, some hypersensitivity reactions, but even those are pretty low. The biggest problem is getting them to be covered by insurance. Now, onto the drugs that target the triglycerides. We're going to start with the niacin or nicotinic acid, and we don't really know quite what the mechanism of action on triglycerides is, but it does inhibit their synthesis. Now, I need you to know that triglycerides being elevated is actually primarily due to a diet that's high in carbohydrates. And I don't ever remember being told that in school. The rest of the cholesterol is impacted more so by that high fat intake. Um, However, the triglycerides need to be monitored along with A1C to see if this individual is increasing their carbohydrate intake or have hyperglycemia. And so we can target it specifically, but in terms of the diet, you need to have those individuals decrease their carbohydrate intake. Okay, off my soapbox. The major side effect is going to be that flushing that comes from the niacin, and it's pretty upsetting and uncomfortable for individuals, but it doesn't happen severely for most people. It can also increase the glucose and uric acid levels, so we have to be careful in our diabetics and our gout patients. Next is the fibric acid derivatives, and these are really good with triglycerides, but pretty poor on LDL. As a result, we're going to only use these on individuals that have that higher triglyceride level, or we can combine fenofibric acid with a statin. It's the only one that's approved to combine with a statin because its side effects are a lot smaller. You'll notice that the side effects are quite the same as the statins, and if you pile multiple drugs with the same side effects on top of each other, it does what we call potentiation, meaning that you're more likely to see severe side effects. These shouldn't really be used with warfarin due to their PK/PD. Finally, you can use fish oils. These are prescription grade fish oils to decrease triglyceride levels. However, they're usually only used as an add-on, and they can affect people who are taking anticoagulants or antiplatelet drugs.